احنا برضو مأجلين الأسئلة بعد السبيكر الثالث. الدكتورة نديمة هتقدم السيرد سبيكر.
السلام عليكم. بدي أشكر الدكتور مصباح وهيئة إدارة جمعية صعيد مصر لدعوتنا. نتشرف وجودنا معاكم، ودائما نتطلع إنه نيجي وقت المؤتمر ونشارك معاكم. وإحنا الجمعية الأردنية للعناية بالسكري يعني بنحب كتير نتعاون مع جمعية صعيد مصر. أنا بتشرف إني أعرف دكتورة عزيزة على قلبي كتير، الدكتورة مروة أحمد. دكتور، وبحب انه يعني اول ما شفت اسمك قلت انا حعرف عليها. الدكتوره مروه استاذ امراض الباطنيه والسكر جامعه اسوان، هي سكرتيره جمعيه صعيد مصر للسكري. صار لي 4 سنين بعرفها وعن جد كل مرة بتفاجئني بعلمها ومعرفتها. تفضلي دكتورة.
شرف لي دكتورة نديمة. بشكر الدكتورة نديمة على التقديمة الجميلة دي. بشكر أستاذي الدكتور مصباح، أستاذ الدكتور ياسر، زميلي الدكتور محمود. برحب بكل الحضور. احنا actually هنكون continuation للspecial population and management of diabetes. هنتكلم actually عن diabetes and elderly. وهل فعلا في difference ما بين diabetes and elderly? Why diabetic elderly are different? Actually, elderly is a continuation of the age after 65. وممكن نقسمهم according to the group of the age into young, old and older old, which accordingly to the age and actually according to the functional state, we can classify them into healthy elderly patients and the patient that having a complex and other comorbidities. لما نتكلم actually زيادة في الage ده بيزود عندي burden for diabetes. Actually in 2000 the number of elderly diabetic patients can about 56 million year, and this is will be doubled on age 2030. Why diabetes is different in elderly patients? Actually because of different pathophysiology and different risk and unique consideration, and they do need a different approach of the treatments. هنتكلم على 3 different cases. Madame Nadia, a female patient, 70 years old, came to your clinic with A1C 5.7, and the patient random was 150. While Mr. Khalid is an old patient, 85 years old, he is Alzheimer and in rehabilitation center, ischemic heart disease, CKD, actually on a basal branded insulin, and the caregiver called you and asked about the recurrent attack of hypoglycemia. While Mr. Ahmed is ischemic diabetic patient, and actually A1C is 7 with a 2 attack of a hypoglycemia, he is on SGL2, metformin, and glimepiride. طب ليه elderly and diabetes in elderly is different? Actually because of the different pathophysiology. The pathophysiology in elderly, according to a different study, the aging will increase the incidence of type 2 diabetes and impairment of the glucose intolerance because of deficient in insulin secretion, لأن بيحصل apoptosis of the beta cell, mitochondrial dysfunction, oxidative stress, chronic inflammation. All these factors will result in decreasing in the insulin release and also increasing in the insulin resistance. Both of them result in increasing in the incidence of type 2 diabetes, especially in elderly patients. Actually, we should screen for the incidence of type 2 diabetes to not miss that by oral glucose tolerance test, and A1C is not triable, and this is old age. Also screening for the micro and macrovascular complications, according to the guidelines, it is the same as the younger patient, and also screening for the unique consideration of the elderly patient, which is geriatric syndromes. 8 different risks with unique consideration اللي احنا بنبص عليه في elderly patient. Actually, the diabetic elderly are more higher for the incidence of the complication, for the incidence and mortality, and also because of increasing in the incidence of the geriatric syndrome. لما نتكلم على geriatric syndromes احنا بنتكلم على cognitive dysfunction, بنتكلم على polypharmacy, بنتكلم على risk of the fall, functional disabilities, frailty, sarcopenia, and urine incontinence. لما نتكلم على cognitive dysfunction احنا variable إلى حد ما from the mild cognitive dysfunction function to cases with a dementia or even cases with Alzheimer, with the risk factor more with a poor glycemic control and increasing the instance of the hypoglycemia. All these factors بتعمل عندي visual cycle والعيان more poorly controlled and more instant of micro and macrovascular complications and dementia disorders. That's why in ADA guidelines in 2024 advise us for screening of an early detection of the mild cognitive impairment by many mental state examination. What about other risk factors like functional disabilities and frailty? لما نتكلم على functional disabilities, actually the main cause is sarcopenia. Sarcopenia is more common in a diabetic patient because of increasing in the protein catabolism, hyperglycemia, chronic inflammation, oxidative stress. All these factors هيزود عندي risk of the sarcopenia more double than elderly patient that have no diabetes. While frailty that احنا بنتكلم على in more the presence of more than 3 of these criteria like unintentional weight loss, self-exhaustion, weakness, and also low physical activity. That's why المفروض ان انت تشوف ال functional state of your patient about the daily activity by different score. طب هل ده بيخلي عندي الجول بتاعي بيبقى مختلف؟ treatment goal is different. وهل ده بنبص على glycemic control بس ولا في حاجة beyond the glycemic control زي decreasing in the cardiovascular risk? Actually regarding the glycemic goal احنا أهم risk عند العيان elderly is a hypoglycemia. Actually the risk of the hypoglycemia is more common in elderly patient because of the age-related decreasing in the renal function, poor and irregular eating pattern, the hypoglycemic unawareness اللي بتكون more common. Actually the elderly patient بيبقى جايب maybe neuroglycopenic manifestation more than neurogenic manifestation لأن نتيجة إن في autonomic neuropathy also العيان بيبقى عنده cognitive disorder. All these factors هتزود عندي من risk of the hypoglycemia. وبالتالي according to different study, according to the ACCORD, an advanced study, an added study, all these studies failed to show a clear benefit from intense glycemic control to decrease the risk of the cardiovascular risk. وبالتالي أنا ما عنديش أي evidence and convenient evidence that elderly patient with diabetes we need for intense glycemic control. فمن الآخر خليك more relaxed in the treatment of elderly patients. وده اللي state actually in treatment of elderly patient in ADA guidelines in 2024 بيقول لي ان انا المفروض تكون more relaxed بس ده different according to your patient. يعني مثلا healthy patient that have a few comorbidities المفروض ال A1C بتاعك ما بين 7 to 7.5 while the complex or elderly with more than 2 comorbidities زي مثلا heart failure, CKD, or patient that have cognitive dysfunction or functional disabilities, you should be more relaxed and the A1C should be less than 8. لما نتكلم على another beyond the glycemic control is the cardiovascular risk. Actually, we all know that treatment of the diabetes, we have 3 pillars: controlling the hypertension, controlling of the dyslipidemia, and also lifestyle modification with the medical nutritional therapy. لما نتكلم على الهيلثي patient الايم بتاعي زي ما قلنا في glycemic control ما بين 7 to 7.5. لما نتكلم على blood pressure should be less than 130/80. لما نتكلم على controlling of dyslipidemia, you should give statin except if there is any contraindication. While the patient that have a complex or intermediate complex or more than 2 comorbidity, you should be more relaxed in glycemic control. The A1C should be less than 8, and the patient should have hypertension. If they have hypertension, the blood pressure should be less than 140/80, and the statin, you should, if the patient tolerate, you should start a statin. About the patient that have a very complex or poorly ill patient, the A1C is not reliable in that patient. And actually, the preprandial or the fasting blood glucose should be up to 180, and the postprandial or the bedtime should be equal 200, and the blood pressure should be less than 140/90, and the statin considered only in the secondary prevention. So, treat the patient, not the number. Our goal is to maintain a function of these patients. لما نتكلم على therapeutic consideration, actually lifestyle modification, medical nutritional therapy, and pharmacological therapy. The aim of the pharmacological therapy, our goal of the pharmacological therapy is to use anti-diabetic drug or any pharmacological therapy with a low risk of the hypoglycemia. That's why ADA recommend de-intensification or simplification of the treatment. ده في حالات ال elderly patient that having a state of unawareness of the hypoglycemia, recurrent attack of the hypoglycemia, abnormal eating pattern, the patient that have a pain وبالتالي بتقلل من الانجكشن, the number of the injection and number of the monitoring, and also the patient in end of life. ده السلايد اللي حضراتكم كلكم عارفينها في ال ADA guidelines 2024 ما اختلفتش كتير عن 2023. هناخد نشوف الكونسيدريشن هل اقدر استخدم كل ميديكيشن انتي دايابيتيك دراج. Actually the metformin is still first and the cornerstone of the treatment of diabetic in elderly, but زي ما قال دكتور احمد cautiously in the patient that have a heart failure or a hypovolemia لان بيزود الريسك of the lactic acidosis على الرغم ما بيحصلش كتير. لما نتكلم على sulfonylurea use with cautiously واكشولي glycoside هو more safe in these type of the patient. لما نتكلم عن TZTs are better to be avoided لأن بيزود ال instance of the water retention and heart failure and also increasing the risk of the osteoporosis in this type of the patient. SGLT2 هو actually the cardio and renoprotective effect, but actually it increases the risk of urine incontinence and urinary tract infection وبالتالي إلى حد ما can be used with a cautiously except in the patient that have a heart failure. In this patient we can use it. In incretin-based therapy, actually the incretin-based therapy, DPP4, can be used safely in this type of the population, special population, while GLP-1 should be used cautiously in the patient that having gastroparesis. What about the patient that having complex insulin regimen? According to the ADA guidelines, if the patient on a basal insulin, you should give the basal insulin actually in the morning, not in the evening. And also if the patient take a branded insulin, according if the branded insulin is less than 10, you should stop it and replace it by non-insulin therapy, oral medication. If the patient had the brandial insulin more than 10, you should decreasing the dose up to the patient يبدأ ياخد oral medication. If the patient على pre-mixed insulin, you should decreasing the dose 70% and you should give it at the morning to guard against the instance of nocturnal hypoglycemia, especially in this type of the population. Our take-home message, actually diabetes in elderly is distinct from the diabetes in younger patient, and the approach of the treatment should be different. In elderly patient with the multiple comorbidities, the strategies should be used strictly to prevent the instance of the hypoglycemia. Start low and go slow is a good principle, especially in elderly patient. Not two elderly patient are alike. Actually, Nadia مختلف عن أحمد مختلف عن خالد اللي شفناه في أول presentation, and they all unique and you need a unique consideration and unique treatment, and thank you.
شكرا دكتور مروة على المحاضرة الجميلة دي.